Welcome to Deep Brain Stimulation, or DBS 101. My name is Joan Miravite. I'm a family nurse practitioner with a doctorate in nursing practice. I'm an assistant professor of neurology at the Icahn School of Medicine at Mount Sinai, the director of interdisciplinary clinical care for movement disorders at Mount Sinai Beth Israel in New York City, the chair-elect of the American Academy of Neurology Consortium of Neurology Advanced Practice Providers, and a Jonas Foundation Nurse Leader Scholar. These are my disclosures. I hope with today's lecture that to help you identify a candidate for deep brain stimulation surgery, compare DBS components and technology, describe DBS programming, assess the interprofessional care of the DBS patient, explain how to educate patients and families about DBS, and to evaluate considerations in PD and DBS patient hospitalization. DBS is FDA approved for Parkinson's disease, or PD, essential tremor, or ET, dystonia, and for the purposes of this talk, I will not be discussing OCD or epilepsy, but those are also FDA approved indications. So, deep brain stimulation, what is it? It's my favorite topic. So this is an oldie but goodie video, and here it shows that DBS is a surgical therapy where electrodes are implanted deep in the brain, connected by extension wire to a battery or implantable pulse generator in the chest. This can be adjusted to send stimulation pulses up to the brain to treat movement disorders. The most common question I get is actually, when is DBS a success? And it's really a success when we have a multidisciplinary team approach, an appropriate candidate is chosen, that patient has realistic expectations about what will happen before, during, and after surgery, that patient has an experienced team around them, and continuity of care. And so those realistic expectations are that DBS is not a cure. DBS is a process. We need to increase stimulation and reduce medication at the same time as the brain is healing. Optimal results will differ for each patient and take time. Most patients will need to continue medical therapy, and in particular for Parkinson's disease, what we see as a response to levodopa is what we will see as a response to deep brain stimulation. So what symptoms respond to levodopa also will respond with deep brain stimulation. And so most patients, when they're evaluated at an experienced center, will be seen by a neurologist or a programmer, a neurosurgeon, a neuropsychologist, sometimes psychiatry. Many centers have PT and speech therapists evaluating patients. They have DBS rounds where each case is discussed, and then extensive patient education. So some programming basics. As you know, DBS is an implantable system that modulates brain activity to improve motor symptoms of movement disorders. And the advantages to having DBS are that it's adjustable. We can change different settings. It can be done bilaterally. Prior to DBS, there were ablative therapies, or where the area in the brain that was actually ablated or damaged, and this therapy could only be done unilaterally. So DBS can be done bilaterally. The therapy is individualized or personalized for each patient, and it's reversible. So in the future, when we find the cure for ET, PD, or dystonia, we can turn off the battery or the IPG. We can actually explant the devices, and the brain will be intact for whatever therapy there is in the future. Disadvantages to DBS are that there are surgical complications, device complications, and stimulation-related complications. So surgical complications can include the potential for a bleed in the brain, infections, device complications. These are devices are man-made, so they can break, they can malfunction, they may need to be replaced. Some stimulation-related complications include dystonia, dysarthria, sensory changes, but the beauty of DBS is that we can change the settings so that we no longer have those stimulation-related complications. And so, as you know, DBS was approved in 1997 for tremor in PD and ET. It was approved for PD in 2002 for treatment in the STN or GPI, and in 2003, it was granted a humanitarian device exemption by the FDA for dystonia. So there are different targets for different diseases. So the STN or subthalamic nucleus is one of the targets for Parkinson's. And here you can see in turquoise blue on the left is the STN or subthalamic nucleus. Around it are many, many structures. And so if we are stimulating within the STN, the electrode is actually in the STN, we can see reduction in tremor, rigidity, bradykinesia. If we are stimulating in the zona incerta, we can actually see reduction in dyskinesia. If we are stimulating in the SNR or substantia nigra, we can actually see depression. If the electrode is a little too deep, if the electrode is a little too medial, we can actually stimulate the red nucleus and see eye deviation. And these pink fibers of the internal capsule that wrap around the thalamus and the STN and the GPI, we can actually, if we're stimulating those fibers, we can actually cause dystonia, muscle contractions, dysphagia, dysarthria. So we need to know where the electrode is and what kind of electrode we're using. For essential tremor, we are stimulating the VIM or the ventral intermediate portion of the thalamus. In green here, you can see these pink fibers are wrapping around the thalamus. And not all of the contacts on the electrode here they're numbered 0, 1, 2, 3. Not all of them are within the VIM. So if the electrode is too close to the internal capsule, we can actually cause dysphagia, dysarthria, and dystonia. If the electrode is too close to this area called the VC, we can get a lot of sensory or paresthesias, and we know that stimulating within the VIM can have profound reduction in tremor. And the last target we use for movement disorders is the globus pallidus pars interna. We use it for dystonia and PD. So here you can see this peach-colored nucleus is called the GPI or globus pallidus interna. Above it in green is GPE, the globus pallidus externa. Just below the GPI is the optic tract. So if the electrode if it's a little bit too deep, it can actually sit in the optic tract and cause flashing lights or phosphenes for the patient. As you can see, the internal capsule fibers wrap around the GPI. So if your electrode is too close to the internal capsule, or you're overstimulating the patient, you can actually cause more dystonia. And subtle signs of dystonia can be dysphagia or dysarthria. And so you really need to know your anatomy and know where the electrode is. There are 4 different parameters that we can change when we're programming. We can change the amplitude or the intensity of stimulation that we're delivering per pulse per second. The number of pulses per second in hertz is the rate or frequency. And then we can change the duration of each pulse or the pulse width, which is measured in microseconds. The 4th thing that we can change is the electrode configuration. And so here I'm just trying to get closer to this picture so I can really show you. In section A here, you see this negative electrode this negative contact on the electrode. The bottom contact is negative, and this little positive sign is meant to represent the case or the battery in the patient's chest. And so when you change a contact to negative, you make that contact the cathode, and the negative contact is actually the active one. And so the negative contact is where you're sending stimulation from, and the cathode, the anode here, the positive, is actually on the battery itself. So this is a large field of energy. It's called unipolar or monopolar. Next to it is bipolar, where the negative or cathode is set on the electrode, and adjacent to it is the positive or anode. And so it's a smaller field of energy. It's closer to the electrode itself, and that is many times used when we have side effects from monopolar stimulation. We can also use more than one contact at the same time, so that's you can have double, unipolar or monopolar, triple, quadruple. But unipolar or monopolar means that the case is positive. You can also have two separate programs on the same electrode alternating between each other, and that is called co-activation. Here it's labeled as interleaving or multi-stimulation. In this B section, it's showing a virtual contact. So on the Boston Scientific device, we can actually use two adjacent contacts together, and the stimulation field between them is like a virtual contact. So it's sending stimulation between the two contacts. Next to that is called the anodal block. And so there are here two negative contacts together, so that is where the stimulation is coming from. And the third contact on that segment is a positive or an anode. Next to that is anodic stimulation, where the battery or the implantable pulse generator is actually the cathode or negative, and the bottom contact on the electrode itself is positive. And so this is not used very often, but it's an option to you as a programmer. And the semi-bipolar stimulation, we see a negative contact on the bottom of the electrode, and there are two positives, so 50% at the battery and 50% on the electrode adjacent to the negative contact. On the bottom here, it's just important for you to know how the electrodes are actually numbered. So on the Abbott device, they're numbered 1. The two middle levels are actually segmented into thirds, and they're labeled 2 ABC, 3 ABC, and the top contact is a single contact labeled number 4. And on the other side, if you have a single battery, the numbering is 9, 10 ABC, 11 ABC, and 12. On the Boston Scientific device, they're numbered 1, 2, 3, 4, 5, 6, 7, 8, and then 9 through 16. On the segmented lead, and also on the 8 contact linear lead. And the older Medtronic device electrodes are numbered 0, 1, 2, 3, and then 8, 9, 10, 11. This is another schematic to show that the electrodes are also different from each other in spacing. So each contact is actually 1.5 millimeters, and the spacing can be narrow or wider spaced. So the narrow spaced electrode has 0.5 millimeter spacing between contacts in blue here, and in the wider spaced electrode, there's 1.5 millimeter space between contacts. So the span is 10.5 in the wider spaced electrode and 7.5 millimeters in the narrow spaced electrode. There is 0.5 millimeter spacing in the 8 contact linear lead, the Boston Scientific lead, and in the B section, these are directional or segmented leads. So there are 8 contacts, but the bottom contact and the top contact are actually single, and the 2 middle sections are segmented into thirds. And the last electrode here is the Sapiens electrode that is only seen in research. And so what we're doing with stimulation is that we're actually just changing the shape of the field of energy. And so I mentioned earlier, co-activation is when we're having 2 different segments activated and power is shared between those 2 contacts. And so we can see that in multi-stim on the Abbott device or interleaving on the Medtronic device. We can set 2 separate programs and they share a frequency between those 2 programs. Or in the Boston Scientific device, we can actually send stimulation from individual contacts independently, and the frequency is not shared. So those are all terms for co-activation. So directional leads. Here on top, you can see that the green spot is the sweet spot. The red area is the sour spot where we're getting side effects from stimulation, and the gray area is the area of current flow around the electrode, and this is a cross section of the electrode. On the bottom left, we see that when we're stimulating all around the electrode segment, on all segments of the electrode, we're actually touching both the sweet and the sour spot, and the goal here is to stimulate only the green area. In the middle diagram, you see that the electrode is, this segment is being changed or moved, so we're actually stimulating away from the away from the sour spot. And all the way on the right, we can see that the stimulation has been sent in the direction of the sweet spot, away from the sour spot, and so this is how directional steering works. We can actually send stimulation in a particular direction to maximize the benefit and minimize side effects. This is another diagram showing that if an electrode is well placed, we can actually send stimulation within the STN. But if the electrode is outside the STN, we can still send stimulation in the direction of the STN to provide benefit for that patient. DBS in Parkinson's. The symptoms that are treated in PD by DBS are tremor, rigidity, bradykinesia, dyskinesia, motor fluctuations, and dystonia. We also treat off medication times. This is from an old paper by Dr. Crack in Germany, showing that in blue, the bottom on the left, in blue is off time, in green is quality on time, and red is on time with dyskinesia. And before surgery, pre-op, before a patient takes meds, they're off and immobile. They take their medication or L-DOPA on the bottom, indicated by the arrow. Their medicine kicks in. They have some quality on time, but then at the peak of their dose, they have dyskinesia in the red area, and their symptoms fluctuate. Their medicine wears off, and then when it kicks in, they have dyskinesia. And so they're really having motor fluctuations in response to medication. On the right, you'll see that post-surgery, post-deep brain stimulation, they're never in this blue off period time. They're really maintained in the green area, and they are avoiding this stimulation with, on time with dyskinesia with stimulation. So it effectively treats their off time and their dyskinesia. This is another study looking at response to deep brain stimulation over time, and you can see that after 6 months, most patients had reduction in tremor, rigidity, and bradykinesia, and after 5 years, this was maintained, and I can tell you after 20 years of programming deep brain stimulation patients that those patients are still seeing control of tremor, rigidity, and bradykinesia, as well as dyskinesia and dystonia. This was a randomized control trial looking at patients randomized either into best medical therapy arm or a neurostimulation cohort. And this top graph shows that their quality of life scores were greatly improved in the DBS cohort. And here on the bottom, that their quality of life scores, they had improvement, statistically significant improvement in most of their quality of life measures. So, what symptoms does DBS not treat? It does not treat cognitive problems, speech, mood or anxiety, gait, or postural instability. And so, when we're looking for a DBS candidate, we really need to make sure that we know the inclusion and exclusion criteria. And so, patients that are good candidates for surgery have a good response to levodopa with exemption of tremor. Their tremor can be refractory to meds, but will still respond to deep brain stimulation. They need to have had PD for at least 4 years and intact cognition. Patients should be excluded from DBS if they do not have a response to levodopa except for tremor, if they have dementia, or if they have comorbidities that may preclude them from having surgery. This video is just to show that if you have the right patient,
All right. Works.
The right patient with well-placed electrode in the right setting, that you can really have a reduction in their most bothersome symptoms. And here, once I get to 3 volts, his tremor just stops, and that doesn't get old at all. In essential tremor, a good candidate for surgery is someone who has essential tremor that's debilitating. Their tremor is refractory to medications, and they have intact cognition. This is a video of a patient intraoperatively. They have severe tremor. They're awake during surgery so that they can be evaluated. This is them trying to draw a spiral. And then once the electrode is placed and turned on, their tremor has stopped, and they can actually write their name for the first time in years. This is a patient before and after surgery.
Sorry.
So you can see here, pre-surgery, that she has severe postural tremor. And you can see how this can be really debilitating for a graphic designer. She can't use her hands. Every time she tries to use her hands, the tremor comes out. And so here she's just holding her arms in certain positions, but the tremor comes out when she's drawing, carrying, writing, putting on makeup, and is completely debilitating and frustrating for the patient. Here is an intention tremor. She's trying to touch my finger, but she can't. And so it's on both sides. She really can't use her hands. And so this is her after surgery. You can see that her tremor is markedly improved. She has a slight tremor, but it's really vastly improved. She's able to write again. She's able to put on her makeup and do her nails. So she's very happy. So DBS for dystonia. DBS for dystonia is a patient who is a good candidate if they have primary dystonia without trauma or lesion on the brain. They should have tried all medications, but their symptoms are refractory to medications, and intact cognition. So this is a patient who has generalized dystonia. So she has a genetic form of dystonia called DYT1, and so it affects her whole body. Many patients that have generalized dystonia have tremor, but she does not. So she has good control over her hands. She doesn't have tremor, postural tremor, or intention tremor. And when you see her foot movements, you can see that her foot is starting to turn inward. So these are involuntary abnormal movements with action, and that is classic dystonia. And here she doesn't have very good control over her foot movement, and she is going to indicate that she's having tightness in the leg when she's trying to move that foot. And you can really see her dystonia when she's walking. She's got internal rotation of her leg, and the foot wants to go up on its toe. And so this is her whenever she tries to walk. Her leg just turns on its own. And so she also has severe writer's cramp. So you can see that she cannot even put the pen to the paper. And her arm wants to just move up from the shoulder up. So she's trying to tuck her elbow in. And so you can see how this can be really debilitating for a lawyer. And this is her 6 months after surgery. She has good control over her hands. And she has better control over her foot movements. And yes, that's her dog. She's very good control over her left foot, and when she's walking, you can see she still has some dystonic posturing in the left leg, but it's no longer turning in, and she's no longer walking on her toe. And her writing has improved greatly. She, in fact, went back to college and got her master's degree. So 1 year after surgery, she is doing very well. She always had good control over her hands, but here her feet, the movements of her feet are really normal, and she is walking well. And so she and her dog are really happy. This is a video of a patient who has cervical dystonia. So you can see before surgery, she's got no range of motion of her neck. She can't even see what I'm asking her to do. She has to turn her entire torso. She can't see where my hand is. This is her posture. She can't drive or perform any ADLs for herself. And so she has surgery, and about a year after surgery, she has full range of motion of her neck. So she can turn left to right on extension and rotation. And when she's walking, she can look forward. And so she has no sign of dystonia at all. And both dystonia patients are off medications. So the goal of surgery is, of course, to put the electrodes in the right place. So patients are typically awake during surgery, some of the time or sometimes all of the time, although there is now a sleep DBS, so patients can be asleep for their surgery. Patients are typically off medication so we can see their symptoms. Many surgical centers will do one side at a time, and other centers will do both electrode placements at the same time or during the same surgery. They will test that electrode in the operating room to make sure that the electrode has benefit and little side effect. And at another surgery, they will implant an extension wire and the battery to connect to the electrode in the brain. So in the past, you can see on the left here, an MRI has not, surgeons were not able to localize the STN or the basal ganglia based on an MRI. And so many surgeons would use or still use microelectrode recording. And Dr. Lozano in Toronto described this procedure as driving through Europe with your windows open, listening to the languages outside your car and knowing where you are based on the language. And so you can see that each nucleus, as an electrode would pass through, has a different language, has a different frequency and firing rate. And then each area between each nuclei is actually quiet. So we can actually see in the operating room or hear in the operating room where we are by passing a microelectrode through. And so there have been many advances in technology. And here is quantitative susceptibility mapping, or QSM. And it's really based on the unique iron metabolism of the basal ganglia. And so you can see that we can really visualize the STN and the GPI and the thalamus here in both of these pictures. And so really beautiful imaging. We also have MRI guided DBS, where the surgeon will actually implant the electrodes in real time in the MRI scanner, and we can directly visualize the placement of the electrode. And the newest thing is image guided programming. And so the image can be rendered in the operating room and superimposed onto the electrode on the programmer, the clinician programmer itself, so we can really visualize the electrode contacts that we're choosing to really help us to stimulate a patient and treat their symptoms. As you know, there are 3 DBS devices. There are Medtronic, Boston Scientific, and Abbott. The Medtronic device has, you can see here on the left, are wider spaced or narrow spaced contacts on the electrode. Here is the 1-3-3-1 configuration of the segmented or directional lead. In the middle here are the batteries. So a single battery for a single electrode, and then 2 batteries that in the middle here can connect to, there are single batteries that can connect to 2 electrodes. There's a rechargeable device, and the newest model of the PC is called the Percept device, and this allows us to use brain sensing technology to help maximize the programming for Parkinson's patients. Here on the top right, you see a patient recharging his battery. This is the charging unit and the patient programmer all the way in the top right. And on the bottom right is the clinician programmer. The next device is the Boston Scientific device. Here's the clinician programmer. On the bottom, you see the 8 contact linear lead. Above that is the segmented lead with 8 contacts, the Boston Scientific battery, and the patient programmer. What I forgot to mention before is that the Medtronic device and the Boston Scientific device are both MRI conditional, so we can have patients have full body MRI imaging under certain conditions. This Boston Scientific device is rechargeable, and on the right here is the charging unit. The Abbott device here on the left, you can see the segmented electrodes, narrow and wide spaced. This is a graphic representation, and again the numbering is 2 ABC, 3 ABC, and 4, and this negative contact 2A and positive 3A, so 2A negative, 3B positive is a bipolar configuration. This device is Bluetooth enabled, uses Apple devices, so we have to pair our device to the patient's battery in their chest. This device allows us to do remote programming, so we can actually work through a patient's Wi-Fi and change settings in real time. And so this device is also MRI conditional and non-rechargeable at the moment. A few words about DBS programming. When we are seeing a patient for the first programming visit, we need to know what happened in surgery itself. We need to know what device was implanted, if there were any complications. We need to know what their symptoms were pre-DBS. We need to know what their symptoms have. We need to have them come when they have Parkinson's off medications. They should bring their medications and their DBS devices with them. Using a systematic approach with documentation is key for you to be able to program the patient in the future and not reuse settings that were harmful or not beneficial to the patient. You review contacts, so we actually will turn on stimulation at different levels of stimulation on the electrode itself, document benefit and side effects. We choose contacts with the greatest benefit and least amount of side effects. And lastly, we educate patients about what to avoid with DBS, what to do during MRI, surgery, and how to use their DBS devices. And so, as I said earlier, we need to know DBS surgery details. We need to know what device was implanted, what target the electrode was placed, and if there were any surgical complications. We need to know patient symptoms before DBS, instruct them to bring their devices with them, and come off medication to their visit if they have Parkinson's. So first thing we need to do is assess the patient. We need to know how they look, what their symptoms are, whether they have tremor, rigidity, bradykinesia, because those are the symptoms that we're going to be able to treat with deep brain stimulation. We need to connect to their device and make sure that their IPG, or their implantable pulse generator, their battery, is set up and labeled as left STN or right STN, or left GPI or right GPI. We need to check both contact and therapy impedances. Why do we check impedances? It helps us to assess the integrity of the system, troubleshoot for device malfunction, and assess for current drain. And so when you see a high impedance, that can mean that there's an open circuit, so there's no flow of energy, that the the stimulation is being impeded, so there actually is no flow of energy. So that could mean that the electrode is not actually connected to the battery. Or there can be low impedance, and that can mean that there's a short circuit. So the stimulation is actually freely flowing. There is no impedance to the stimulation flow of energy, and so that can mean that there is a short circuit. And many times a patient will actually report burning sensation where there is a short circuit. So we need to check impedance to make sure that we are looking at the integrity of their stimulation system. This is just a video looking at the voltage calculator. And so just to show you that when you have normal resistance, here I'm going to enter 580. The current at 1.5 on top is equivalent to 0.87 volts. But when the resistance or impedance is 1,000, the current and voltage is equal. As the resistance increases, so here at 2,000, the current is 1.5 and the voltage was 3. And the higher the resistance, the more risk you are for causing overstimulation to a patient. So you need to tread lightly when the impedances are high. So the baseline settings that Most centers use is a pulse width of 60, frequency of 130. As I said earlier, the negative contact is the active one, and we set the bottom contact as the negative or cathode, and then the battery as the anode or positive. Then we increase stimulation slowly, voltage or milliamps, in small increments, and assess patient symptoms as we increase. So we want to look for benefit or side effects. We'll move up to the next level once we've increased stimulation to see benefit and or side effects at higher settings. We'll check each level of contacts as we're evaluating the patient. We choose the contact with the most benefit at the lowest setting and with the least amount of side effects. In Parkinson's patients, I like to reassess my patients after they take their meds and their meds are working, and then educate on how to use their patient devices. And some clinical pearls as you're programming. The stimulation benefit on rigidity can last for a few seconds to a couple of minutes, so it's best to let the stimulation wash out between contacts, and so just turn off the stimulation and wait a minute before you turn the stimulation back on the next contact. Tremor can fluctuate or worsen with anxiety. Bradykinesia can take time to improve with stimulation. Axial symptoms take time to improve. And dystonia can sometimes take weeks to months to improve. So lastly, long programming visits are not always fruitful. It's exhausting for the patient and can be frustrating for you. So it's not always helpful to have long programming visits. In follow-up visits, we assess patient incisions, reconcile their medications, evaluate patient symptoms, document their DBS settings, adjust settings to maximize benefit and minimize side effects, reinforce those realistic expectations of DBS, and make referrals to the multidisciplinary care team. And so I really lean on my PT, OT, speech, and behavioral health social worker colleagues to really have holistic care of my patients after surgery. Also, again, in follow-up, we reassess their DBS expectations, educate them on wound surveillance, programming, devices, and medication adjustments, educate them to notify their other providers regarding DBS, and then DBS contraindications, cautions, MRI conditionality, and cautery. So a few words about telemedicine. This is actually a video showing a DBS remote programming visit. And so my patient here is connecting to his remote care, and I'm connecting to his battery. And so he starts the visit, and I connect to his battery. And so here he is in his room where he can see me once I've connected to his battery. And so I can see his picture and he can see my picture. We can speak. I've just got the volume off here, but you can see his tremor in his left arm. And I'm going to change the size of his picture and move my picture out of the way so I can really visualize his tremor. And I'm able to examine him. I'm going to ask him to hold his arms out, and you can really see that his tremor is also postural as well. And I can do rapid alternating movements, and he's got some bradykinesia on his left hand. And I'm going to check his impedance and check his battery. It's on. Check his impedance. And so that's his therapy impedance. I'm also going to check his system impedance and everything looks fine. Here you can see his tremor in the left hand. I'm going to actually change the step size. You can move up in larger increments if you want to. And so here I'm increasing his stimulation slowly and assessing his symptoms at the same time. So I'm really watching for that tremor and asking him whether he's feeling any side effects. And so once I get to 1.8, and 1.9, his tremor is much better. So you can see he doesn't have that rest tremor. And I've had to increase to 2.2. And so you can really see, you can change his settings in real time and evaluate them through remote programming. So some useful tools to give to patients when they're thinking about surgery are these booklets. Here on the top right is Surgical Options, that is from the Parkinson's Foundation. And on the left here, I've had the privilege of working with the Michael J. Fox Foundation to edit this Deep Brain Stimulation and Parkinson's Guide for patients who are thinking about deep brain stimulation. And so these are available online and free to patients. The Aware and Care Kit is here on the bottom, and this has materials that can help educate caregivers, healthcare providers in the hospital when a patient is hospitalized with Parkinson's. And so these are a few useful tools to share with your patients. So some further patient education. You need to help a patient be vigilant about infection, know signs of stroke, how to do wound care, notify you about abrupt changes in their symptoms, and how to use their DBS devices. And so some post-DBS considerations. When patients are hospitalized, we need to make sure that they're provided PD meds on time every time. They should not substitute medications or stop levodopa therapy abruptly. They need to resume their medications when able. And if they need an antipsychotic, they should use quetiapine or clozapine. Watch for symptoms of dysphagia because these patients are at risk for pneumonia. And their DBS needs to be turned off for surgery, MRI, EKG, EEG, or EMG. This is a list of medications that are safe and medications to avoid when you have Parkinson's. This list is in the Aware and Care Kit from the Parkinson's Foundation that you can order for free for patients. Safe medications to use are in the middle column, and medications to avoid are on the right. Just a few words on these medications. Most antipsychotics are actually dopamine blockers. So if you prescribe an antipsychotic like Haldol to a patient that has Parkinson's, you can really make their Parkinson's much, much worse. Pain medications, you need to be careful if they're taking selegiline or rasagiline. It can actually cause confusion or psychosis. You need to be careful when patients having anesthesia for surgery if they're taking selegiline or rasagiline. And many people don't know this, but the antiemetics that we use routinely after surgery are actually, many of them are actually dopamine blockers as well. So prochloromethazine, metoclopramide, promethazine, these are all normal floor stock on surgery floors. So you need to be aware that if a patient has Parkinson's, that they need to avoid these and use things like Zofran or Tigan. And so these are a listing of all the colleagues in my multidisciplinary team. So I work very close. I work in neurology, so I work and am considered a movement disorder specialist. I work closely with the neurosurgeon, other NPs and PAs and nurses, psychiatry, neuropsych, PT, OT speech, genetic counselors, social worker, researchers, and movement therapists. And so, in conclusion, I hope that I've helped you identify candidates for DBS surgery, compare DBS components and technology, describe DBS programming, assess the interprofessional care of the DBS patient, how to educate patients and families about DBS, and considerations for PD and DBS patient hospitalizations. These are my references, and if you have any questions or have ideas you want to bounce off of me, please feel free to contact me. This is my email, joan.miravite@mountsinai.org. And I'd like to thank the Parkinson and Movement Disorder Alliance for allowing me to share this information with you. Thank you.